Alumni engagement here at the University of Toledo. It's a pleasure to welcome you to the College of Medicine and Life Sciences Continuing Medical Education Program. We're so pleased to have Dr. Cheryl McCullumsmith with us as our speaker this evening. She is the chair of the Department of Psychiatry here at the University of Toledo. She holds a medical degree and a PhD as well. She completed her MD, PhD in psychiatry residency at the University of Michigan. She is a board certified in general psychiatry and consult liaison psychiatry. She's a member of the American Psychiatric Association, the Association of Emergency Psychiatrists, the American College of Psychiatrists, and a fellow in the Academy of Consult Liaison Psychiatry. In addition, she serves in several leadership positions on national committees, including the Emergency Psychiatry Special Interest Group, educational and research committees for the Academy of Psychosomatic Medicine, the Board of Directors, and she's co-chair of the Treatment-Resistant Depression Group of the National Network of Depression Centers. Her expertise includes treatment-resistant depression, medically ill populations, improving quality of care, and developing novel treatment interventions for patients in psychiatric crisis. She is currently focusing on developing interventions to enable patients to connect with appropriate follow-up care after psychiatric crisis and suicide. It's a pleasure to welcome the chair of our Department of Psychiatry here at the University of Toledo's College of Medicine and Life Sciences, Dr. Cheryl McCullumsmith.
Okay. Hi. So today I'm going to be talking about some programs that we've been working on here in development of treatment services for opioid use disorder and pain. It's been a major initiative of ours in helping with patient care and prevention of poor outcomes, including death. So we've been working on a continuum of care that we're calling the University of Toledo Center for Healing. We would like to be able to provide mental health and substance use treatments for patients at any point at which they need the care or present. And also, we, as an educational institution, have a mission to provide training to all levels and disciplines of providers, including interactions with emergency medical staff, fire departments, certificate training in expertise for social workers, therapists, and physicians. And so we'll be talking to you, I'll be talking to you about some of these things. So I think it's worth going back to the basics. I always think it's good to take a step back and really understand the issue. So we talk a lot about the opioid epidemic and opioid use disorder, but what are opioids doing in the brain anyway, and why are people using them? So if you go back to even basic question, what is pain? So there's no objective, there's no reason that we should feel pain when we hit our hand on something. In fact, there are many disorders where people don't feel pain. So, you know, what does this do? Pain is when you have a breakdown in tissues of, you know, cancer cells invading or inflammation or tissue injury. It creates noxious factors that are picked up by specialized receptors called nociceptors for pain receptors. And these signal is brought back to the brain via interneurons in the spinal cord and creates electrical signal and a response that we think of as pain. And it's meant to help us survive, right? So that we get away from, I'm having some issues here. That we get away from these noxious things. You don't want to leave your hand on the burner on the stove, right? That's not a good thing. And the body doesn't have opioids, but it has natural chemicals called endorphins, and there are specific receptors for each type of endorphin that are distributed in unique ways throughout the body. There are more than 3 classes, actually, because there are subclasses of all of these, and they have unique roles and functions. So there are mu opioid receptors, mu, green, right? And you know, your endorphins come in here and make you feel better, right? And we'll talk more about how they do that. Just like I actually get a little jolt of happiness every time I successfully do this, even though I've done it thousands of times. So, and similarly, the endorphins kind of pop in and out like this, and they're specific for their type of opioid receptor. So there's mu, kappa, which is a different color, and delta, and I seem to have lost my purple ball. So they're separate, and they stick with their own type of receptor and have specialized functions generally. And we'll talk about what opioids do to that in just a second, to this kind of very nuanced system that the body has to help us with pain and also help us to avoid pain. So, and this is talking about their very specialized endorphins for each subtype of receptor. So we have these natural endorphins that are, you know, popping in and out of our endorphin receptors all day, right? All through the day, hopefully, if we've got this going well. And we don't become addicted to the normal things that cause us to release endorphins generally. So why do opioids lead to abuse and dependence? And it's because they hijack some of these natural endorphin systems, especially pathways that the endorphins are involved in called the reward pathways. So we're going to talk about reward circuitry here, and it is a circuit that is largely dopaminergic once it leaves the ventral tegmental area nucleus accumbens and goes to the prefrontal cortex here. Also has serotonergic networks coming from it, but in the center of this, in the core of the reward circuitry in the ventral tegmental area, there's a heavy involvement of the mu opioid receptors. And when I say reward circuitry, we all think about getting like a trophy or something like that, but it's neurobiologically, it's not meant like that. It's actually a survival network, if you can think about it that way. The reason we feel reward, that we enjoy food, especially sweet food, that we are interested in love and romance and even sex, in drinking, in things like rubbing your back, why that feels good, because it's cleaning you. These are all survival. Huddling behavior affects the reward circuitry, and parental behavior affects reward circuitry. And so we know the mu receptor is critical for this, and in mice and rodents, we don't do these experiments usually in humans, you can stick a little electrode in and measure the dopamine levels in this circuit after they receive food or have sex, and you can see that those rewards that are essential for survival increase the dopamine level, so this reward circuit directly activates it. And substances of abuse also activate this same reward pathway with high spikes in dopamine without the food or other stimulation necessary. So what the drugs are doing essentially to the reward circuitry, and these spikes are much higher and can last much longer than our normal endorphin spikes from food or drink or connecting with people. And so these substances of abuse are essentially telling your reward circuitry, I, the drug, am the most important thing to your survival. And so they are, the reward circuitry becomes attuned to any stimuli that can help you to get the drug, because it kind of believes that this is essential for survival. And so, you know, why do they, you know, why do we perform actions to achieve things like this rat or mouse running in the wheel, right? So why do people do things to obtain substances that they're addicted to? Because this reward circuitry that I showed with initially with just a simple arrow touches on many of our essential circuits in our brain and connects to them. So if you think about it, if you're a hunter-gatherer, if you find a really good source of food, a good source of nuts or berries or something like that, you need to engage in your memory circuits to remember where that berries were, right? So that's some of the first ones here. You need to have motivation and drive. And so it's interesting, we don't think about motivation and drive a lot with reward, but you have to have drive to go to the grocery store or make yourself some food or do some of this. So there's motivation and drive, and these get hyperactivated so that there's a huge drive to obtain the drugs. And there's also a loss of inhibitory control in this case. And so there's no cortex saying don't go do that. And then here is the reward and salience. So salience means the meaning. And so these reward and salience circuits are extremely activated by substances of abuse, so that these are viewed as the most salient, most important compounds for survival. So it really hijacks this natural circuitry. Now, there is a complex interaction of susceptibility to addiction to substances that's a combination of genetics and environment. And I'm just going to go through this quickly, but it actually has a similar basis in genetics and environment to any other medical illness. So it is a complex interaction similar to the complex interactions of genetics and environment for heart disease and diabetes and others. So this is just a quick slide, and we will be looking at some more of these pictures like this. This is a slice of the brain showing that those areas in the reward circuitry we were talking about, and showing the stimulation of dopamine receptors and numbers of dopamine receptors. So brighter colors like reds and oranges indicate higher numbers. And so they took, these are humans, and who are not addicted to any substances and have never been exposed to any substances. And they divided humans into those who naturally had higher levels of dopamine receptors and those who naturally had lower levels. And what they found was it was a clear separation of those who had lower dopamine receptors found the administration of methylphenidate, which is an amphetamine substance. They found this much more pleasant than those who had high dopamine receptors, found it actually unpleasant. So your natural distribution of dopamine receptors can affect whether or not you find this substance rewarding or not from the beginning. There are also, we know that there are methylation and other genetic modifications that happen with stress and trauma, especially early adverse childhood events, and witnessing violence, that can really predispose individuals to using substances. And it may be that some of these events also are altering the reward circuitry before an individual ever even begins to use a substance, so that the first time they use a substance, their reward circuitry is already in a partially damaged state and much more susceptible. So this shows an example of this that is kind of cute, unless you're a rat, I guess. So these are, again, dopamine receptors in rats. And they took rats that were individually housed, and they had low dopamine receptor activation, okay? And because being individually housed, if you're a rat, is a stressful thing. So it was stressful, they had lower levels. They when they put them into group housing, the rats that became dominant were no longer stressed and had high dopamine receptor levels. And interestingly, they're in green over here, they were not that susceptible, did not find cocaine nearly as reinforcing as the rats who became subordinate and had continued stress or perhaps even more stress. Those rats had, in the red, had much more reinforcement from cocaine. So the reward, the basic setup of your reward circuitry, either from genetics or from in your environment, can dramatically alter your responsiveness to the drugs initially and also your susceptibility to continued reinforcement. So what happens when people are using opioids over time? What happens to your endorphin levels? And I have this kind of pictorially here. It helps if you have more people to help. Sometimes I'll get audience members to help, but if this is your natural endorphins, so you have all of these receptors that have endorphins, right? Catching the ball or not. And if the opioids come, they're just relentlessly coming and trying to replace this and occupying the endorphin sites for too long. So here on the right-hand side are the receptor sites, and you can see normally you have 1 or 2 endorphins coming over and popping in and off. The opioids come in and stay more stuck, and there's many more of them. And so the receptors decide, you know, this really isn't much fun anymore, right? They pull back from the membrane because they're overstimulated. And so individuals can no longer experience normal endorphin activity because the receptors just even aren't there on the surface to be stimulated by the naturally occurring endorphins. So it changes the whole reward circuitry so that individuals are not as responsive to the normal endorphins and need more and more stimulation like heroin to get any response. So addiction is a disease, a long-term disease like asthma or diabetes, where the individual has an overwhelming desire to find and use drugs, even though there are dangerous consequences. And hopefully we've seen here from the neural circuitry that gets activated why that happens. There's a neurobiological basis for this. And it's considered a brain disease because the drugs change the brain. We've also seen some evidence for that. They change its structure and how it works. The changes can be long-lasting and can lead to the harmful behaviors. So seemingly acting against your own best interest because your brain reward circuitry does believe it's acting in its best interest. So when people go into withdrawal, there are many, many brain circuits that are activated that lead to craving and withdrawal because you've had this overwhelming saturation of these receptors. And so now you no longer have as many endorphin receptors. And so there's a significant lack of ability to feel pleasure and significant cravings and multiple effects. And these effects happen not only in the brain but throughout the body. We'll get into this too much, but opioid receptors are present throughout the body for pain reception, for reward in the brain. They're present in the intestine for intestine functioning. That's why if you use opioids, it can often cause constipation. And when people are withdrawing from opioids, they'll have severe diarrhea and body aches and other things. So it's system-wide. So how did we get into this mess then with opioids, and why are so many people taking so many opioids? And it goes back to people. And physicians, we helped to create this mess. In fact, probably a major player in this, as well as some pharmaceutical companies. So probably with good reason, chronic pain was viewed as being undertreated by many medical groups in the 90s, including the American Academy of Pain Medicine, the American Pain Society, and many others. And and recognition of pain and treating pain adequately became a priority. However, it's important to keep in mind that a lot of these groups were talking about more chronic, what I would call malignant pain, like in hospice patients and cancer patients, things like that. And there was a letter to the editor, a letter in New England Journal of Medicine in 1980 that became cited 693 times, probably more now. And so not an article, a peer-reviewed article, and it said only 4 cases of addiction were found among close to 12,000 patients treated with opioids. And so this became highly cited and more evidence that opioids were safe. So you can see here the total sales for Oxycontin between 1996 and 2002 just skyrocketed. So in 1996, there were about 45 million sales and about 317,000 prescriptions. By 2002, so not even 10 years later, it went from 400,000 prescriptions to over 7 million prescriptions, which is quite tremendous, right? And that had an impact. And just in case you think that maybe pain was increasing for some other reason, this is looking at worldwide, the international use during 1 year, 2010, per capita for each person in internationally, a combination of 6 of the most commonly used powerful opioids. And you can see that we're only bested by Canada in our use per capita of opioids. And the next one down, Denmark and then Germany are, almost half our amount per capita. And then Japan is, 26 morphine equivalents per capita versus our close to 700. So it's kind of dramatic. So I did want to touch on that prolonged drug use, and sometimes even the initial drug use, can change the brain in fundamental and long-lasting ways, which is why individuals with addiction need long-term treatment. Similar to someone with diabetes often needs long-term treatment, even with a type 2 or more acquired diabetes can need long-term treatment because there can be long-lasting changes. So it's the same for addictions. So we're getting used to looking at these slides of dopamine receptor availability. Remember how I talked about that for the endorphins even, if they're totally filled up, the receptors go away, right? And so what they've shown on the left-hand column of the purple brains here is controls who aren't addicted to substances, and then various substances of abuse, cocaine, methamphetamine, alcohol, and heroin. And you can see that they're not as colorful and they're cooler colors. So there's less dopamine receptor availability to receive a signal when people are addicted. And even 80 days after detox and cessation of use, the dopamine system is not entirely back to normal. So on the left is a normal brain, and on the right is someone who has not used, in this case, methamphetamine, but similar for other substances in 80 days. So we went over this some at the beginning with these circuits that are involved. So why can't people just quit? So remember talking about the inhibition of the prefrontal cortex, which is your control, shown here on the top. So in a non-addicted brain, there's a significant amount of control saying, no, don't do this for a drive, and not a lot of salience for a substance of abuse, not a lot of meaning. But on the right-hand side, what happens is there's an awful lot of meaning and relevance attributed to the drug, an increased drive to use, and an inhibition of the control. And memory is also involved. The memory circuits help you remember where you used, what it smelled like, what it looked like, what it sounded like. And so all of these things form as triggers to start the whole circuit going again. So we do have many effective treatments, and I wanted to go over what some of these look like. Many folks have heard of Narcan or Naloxone. So this is Naloxone is a treatment for opioid overdose. So if all of someone's receptors are filled and stuck with opioids, they cannot. And I had a better example, and I brought the wrong one, where this will actually stick in there and stay. But leads to respiratory suppression and death. And what naloxone does is displaces the natural opioids and sticks in there tight. See here, it's like gum. I had one of these that I put like sticky stuff in all of them, so it stuck, but I brought the wrong kit. And so it sticks in here, as you can see on the bottom, and the opioids can't get back in. Even though these stick more than the natural endorphins, the naloxone just stays. And so that displaces the opioids, so you relieve the respiratory suppression and people can breathe, and it's a pretty immediate effect. But if there's stronger or longer acting, tighter bound opioids like fentanyl or carfentanil, then this may never be able to displace them, because this has to wait for the opioid to come out to get in there, right? And normally they do come out with some frequency. So stronger opioids take more doses of Narcan or higher doses to show an effect. So, I lost my thing. Other medications you may have heard of are things, treatments, longer-term treatments for substance use disorders. One is methadone, which has been around the longest. And so methadone is a form of an opioid that just is longer acting and doesn't really pop out very often at all, and is very, it hangs out longer, and you're not going to get this reward you get from the popping in and popping off. Every time you, just like when you're playing the game, every time it comes in and out, it's a little bit more rewarding. So the methadone just kind of is longer acting and stays around longer. Buprenorphine is Suboxone, and whoops, I don't have. So what buprenorphine does is it sticks in here better. It doesn't activate all the way. It doesn't go in all the way or activate all of the same way as opioids or the endorphins, and it sticks around longer. So we call it an agonist and an antagonist. So it's partially activating, and it sticks around longer. And so because it's sticking around, it's keeping the opioids from activating all the other stuff that they would normally be activating, if that makes sense. So it does not have as much, it is not as addicting, and helps keep people from using, because the opioids also cannot come back in at the same time, and helps people to be much more stable and a longer term effect. And naltrexone, Vivitrol, is a monthly injection, and it just blocks the receptors from anything binding, similar to kind of naloxone. And there's variable evidence, so that would keep the opioids from working, and might also, have an effect on the endorphins, but certainly keeps the opioids from binding and interfering with the reward pathway. So recovery is a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. And I think we think about this as being particular for substance use disorders, which this is, but really, if you're recovering from a heart attack, from a diabetic crisis, asthma disorder, this is similar for any illness that you're recovering from, right? To improve your health and wellness, live a self-directed life, and strive to reach your full potential is the aim in treating any illness. And what these medications allow us, patients, to do is to live a self-directed life and to not be dependent upon the opioids. So I want to point out that the rates of relapse for addiction in general are actually quite similar to relapse for type 1 diabetes, hypertension, and asthma. It's actually not much different. The difference is, I think, there are generally more profound social, economic, and morbidity and mortality consequences for drug relapses. So we know that buprenorphine works well. These are two studies, one of them contrasting one study that was had the larger treatment effects and one with a smaller treatment effect, but still quite significant. So the y-axis is the percentage of people who are using opioids, so lower is better. So on buprenorphine, people use significantly less opioids than not receiving buprenorphine. So that's a good thing. It also has been shown to increase the amount of time in treatment, just generally, right? So people coming to treatment, getting therapy, getting the medications. So you can see there's a pretty steep drop-off curve for people not receiving buprenorphine compared to those receiving buprenorphine. So if they're not receiving the medication, almost all patients are out of treatment by 50 days to 60 days with buprenorphine. There's some attrition, and patients may not be 100% abstinent, but they're staying in treatment and engaging. So it's been shown to reduce cravings and mortality, increase retention in treatment. It's been demonstrated over and over again to decrease overdose deaths. In France, it was introduced in 1995, and overdose deaths decreased by 79%. And also has been shown to reduce healthcare and criminal justice costs among patients who are receiving them. And there is evidence that your brain with time can recover. So in many individuals, they need to have these medications lifelong, but there is some evidence beginning that after 14 months or several years, that individuals' brains may recover enough dopamine receptor function that they're able to remain abstinent, but without medications. But this is an area of further research. So it is encouraging that with treatment, when you wait many years, individuals can regain some of their dopamine receptor function. And to me, this would be similar to someone who developed type 2 diabetes with obesity, and it would take a few years, right, to lose weight, get a healthy diet, exercise, and eventually that person might have a decreased need for medications for diabetes, or perhaps no need at all, but it's a kind of a similar time course. So I wanted to talk a little bit about some of the programming that we're doing here at UT and in collaboration with partners across the state and the nation to work on some other programs, because just having the medication is not enough, just like for most other illnesses too, right? So we are having a multi-pronged approach, as I described at the beginning, to educate all of our providers and also to provide access to care for patients for prevention of opioid use disorders and treatment and early interventions. So we are part of a CSIP program, a Care Innovation and Community Improvement Program from Medicaid in this state. That's 4 academic sites, us, University of Cincinnati, Ohio State, and Metro North. And each of us are developing our own programs to improve outcomes, especially patient outcomes, especially around opioid use disorders. And in our site here at University of Toledo, we have I'm counting here, 5 steps we're taking, largely, to address the problem in a comprehensive way. We are working on improving our provider prescribing information, so getting prescribers more information about their patients' opioid use and educating them more about how to prescribe appropriately. And we are screening all patients for at-risk opioid use and providing with that, implementing what we're calling an ambulatory care management program. So there are opioid care managers in our primary care settings performing these risk evaluations, from looking at objective data on prescriptions received, as well as any subjective reports they might have from clinicians or others. And they are providing on-site counseling to the patient and to the physician about what might be done with at-risk opioid prescribing or to help manage pain. We are increasing the availability of medication-assisted treatment, which is medication-assisted treatment, or MAT, includes methadone, buprenorphine, and Vivitrol. And we are training more individuals to provide this, and we're providing support for our primary care physicians to offer MAT in the clinics, because it does involve some social support, clerical support, and therapy for patients to work optimally. And we are establishing a pain rehabilitation center here as an alternative, because it's not reasonable for individuals in pain to not receive any treatment. And we know there are very effective treatments for pain that do not involve opioids. And so we are just in this month opening up a comprehensive pain rehabilitation center, which I'm very proud of and happy about. So we came up with all of these programs in a very fun way. We spent about 6 months last year having weekly interdisciplinary work group meetings involving many different disciplines and many different specialties. So nursing, social work, pharmacy, administration, and primary care, emergency medicine, psychiatry, surgery, anesthesiology, many others, because we wanted to have a comprehensive approach and not let any of these programs that we're starting be viewed as just a psychiatry thing, or just an emergency medicine thing, or just a physician thing. We wanted to have a comprehensive approach. And from that, we came up with the programs that I described there, and these programs are meant to provide wraparound care. It also involves providers at all levels of care. So we're involving social work providers for the care management and nursing. We're providing screening at the level of nursing and care management, education in our classrooms, and administratively to providers. And we have therapists who are helping with the providing counseling in the primary care setting and in our pain rehabilitation center. So we're involving, and we have pharmacists involved throughout this to help us screen for at-risk and pharmacy consults. So we're really proud of this interdisciplinary and interprofessional approach. And this is important because, you know, one of the things that we're educating our physicians about is that the evidence is very strong that opioids do not work for chronic pain. Now, it can be very difficult to come off of opioids once you've been on them for a long time for chronic pain, but opioids really should be used for acute pain and don't demonstrate much effectiveness for chronic pain. And so we need to have an alternative, and we need to educate, and there are many treatment guidelines and protocols to help determine who might need long-term use and for a more malignant pain, and to give people guidance about what pathways to do. So we are initiating some of these pathways and protocols in our clinics and helping people with therapy resources and pharmacy backup. And we also are providing the pain rehabilitation clinic. I don't know where my slide went for that, but we also are providing, I think it's coming up, but a pain rehabilitation clinic as an alternative, as an adjunct. So we're not just taking away opioids, we are providing alternative treatment to help with pain. So we're kind of, if you view this like a business, we're looking at our distribution. So we often don't look at this as a business model where we're providing a service for our patients, right? And we should be trying to help them to access our services. We kind of tend to sit back and wait for them to call us. So part of our approach to the distribution on the left side here is this collaborative care approach we're calling in the primary care, where we have therapists and pharmacists involved in helping and identifying people early on. We also are setting up on the right-hand side in the emergency department and having opioid counselors there, and we've improved our access to care from the emergency room so that it's immediate. And some of that has to do with the overdose response team grant that we have from SAMHSA through the state. And this is a collaboration with the Mental Health and Recovery Services Board and our site. We have created an overdose response team, and we are working with emergency medical services, fire, and police to be out with them on runs when there is an overdose. We're creating a center at UTMC that is that's an overdose response center, like you have stroke centers, and specialized care so that we can provide immediate access to needed treatment such as buprenorphine. Because what we know is that when you give somebody Narcan, they go into immediate and severe withdrawal. And so, as you've seen from the neurophysiology of this, their brain thinks that the substance is the most important thing, and they literally cannot think about anything but using and finding more substance. So it's no wonder that when we give patients a phone number and say, here, call there tomorrow morning or 2 days from now, or go talk to a therapist and we'll get you the medication treatment in a week, that they don't succeed. And those patients are at very high risk of overdosing because they've lost, even after a day or two, you've lost a little bit of tolerance. So we are taking all of the available resources in the community, kind of like a drawstring bag. They're all there, but we're just bringing them together so that we are offering transportation directly from the scene, from overdoses to our overdose response center. We are offering immediate access to buprenorphine and very rapid, if not immediate, access to our inpatient recovery services for observation or needed inpatient stays. And then we've also coordinated with all of the, most of the community agencies providing opioid treatment so that they get patients in within 1 to 2 days, so that we have a seamless continuum of care and the patients aren't having to figure all this out while they're in opioid withdrawal and trying to initiate treatment, which is kind of where we've been before. So we're very happy with this team. And that was going to be a slide. Oh, here's my interdisciplinary pain slanter slide. So we have this. This is we have biofeedback programs. We're offering a 7-week boot camp with, in the Department of Psychiatry, I've hired some physiatrists, well, not psychiatrists, but physiatrists, PM&R docs to help with this. Physical therapy and occupational therapy, but not necessarily the traditional. This is very much based on increasing mobility and decreasing pain. We're hiring yoga and acupuncturists as well to really help provide a whole patient approach, as well as intensive therapy for pain management and cognitive behavioral therapy. We're also working on the supply chain. We have a very exciting grant from SAMHSA, again, to provide an integrated curriculum teaching about opioids and the risks and benefits of using opioids, opioid use disorder, and managing pain throughout the curriculum. And as I said, we're also focused on really educating our primary care physicians, but all of our physicians, about appropriate prescribing and how to appropriately use medication-assisted treatment. So this grant for looking at opioid use disorder, we have taken through all 4 years of med school, and instead of having opioid use disorder being put into one psychiatry lecture on your psychiatry rotation or one lecture about pain in the first year curriculum, we are putting this throughout the curriculum and throughout all 4 years, and we're also putting it into every rotation, clinical rotation that the medical students are doing, so that they're learning about pain management in that specific specialty. So In surgery, they have a module learning about managing acute and postoperative pain and how to transition people to home. In internal medicine, they have one on modules on managing pain and opioid use with chronic illnesses. In family medicine, we have some evidence-based pain management and office interventions and screening. In neurology, we have pain syndromes that are can be more complex with pain, migraines, things like this. So we are doing this, and we're creating a toolbox for the medical students that they can refer back to. Their lectures from their first and second year with these clinical rotations. And by the end of the fourth year, we want all of our medical students to have trained so that they could get a data waiver to prescribe buprenorphine by the end, and they will have had all of that education to apply for that waiver should they choose to do so. And they'll at least understand much more about the appropriate use of the buprenorphine and other medication-assisted treatment, and we're hoping that many more choose to prescribe these medications. So in summary, we were talking a lot about opioids and our treatment programs and what they're doing. So we talked about opioids, pain, the role of endorphins, the role of reward circuitry, and addiction, what that means, and treatments, and some of our new work. And again, this is our goal that we're working towards, and that I think we all should be working towards, is to be able to reach patients with effective treatments wherever they're presenting. If it's in the emergency room, in a primary care office, in a hospital setting, in a school. And we need to train people to be sensitive to these topics and to be aware of treatment options at all levels. So, you know, our overdose response team wouldn't work if we didn't involve fire, EMS, and police, because they're an integral part of this, and they're our first line. And training medical students that everyone needs to be thinking about these issues, and also providing more certificates and education for allied health professionals and other disciplines and professions. And so, excuse me, starting to cough here at the end, but that's my talk, and thank you for listening. I don't know if there's questions or, yep.
Thank you for a very comprehensive talk, from the biological to the psychosocial. So you indicated that there are multiple risk factors involved. I mean, certainly pain, but socioeconomic distress might be another. There might be certain comorbidities. I find this to be a complex situation and very difficult to prioritize what I should be doing. If I were looking for maybe high blood pressure, then perhaps I would have a scale that I could simply plug into the various factors and then turn out a simplistic answer as to whether a person is at risk or not. Mm-hmm. Does such a combined means or a simplistic answer exist for this kind of condition?
So we do know some factors that place you at risk. There are some opioid risk tools that are out there. Right now in our clinics, for the first pass, we are looking at the opioid risk tool that was developed by the ORJ reporting system. And they have an opioid risk score on there, and it's actually quite complex. They look at the frequency of prescriptions, the total opioid dose, and prescribing by multiple providers and things like that. But you know, that is really getting you after the fact. But it's somewhat after the fact, but we're trying to address this in the primary care setting before individuals, you know, become cut off from their medications. Because, you know, what happens is those individuals kind of percolate along, and then eventually somebody says, gosh, I'm not going to prescribe you this amount of opioids, right? And then they leave the clinic, and then their problems just escalate, right? So we're trying to do some prevention from really escalating into full-blown opioid use disorder. But we know so when you talk about predicting hypertension, so I don't know that you have a scale to really predict who would develop hypertension, right? It's the same thing that we would use here, which is family history. Adverse childhood events predict asthma, predict hypertension, predict diabetes, predict, substance use disorder. So, family history, lifestyle, eating, socioeconomic status, all those things impact all of our illnesses. So it's an interesting thing. So if we can work on this for opioid use disorder, our hope is that these social determinants of health and predictors might actually help us with other, I call them body illnesses, like hypertension, diabetes, and other things. So.
Is there much of an interfamilial component where if a parent has been addicted at a certain point, the provider is on alert for either other family members or the next generation? Or is it overinflating the situation?
No, I definitely, if I hear about a strong family history of addiction, I'm much more in tune, or, to any substance, because I do think that your natural predilection towards finding these substances appealing or not appealing is demonstrated here by one small study, but does have a strong genetic basis. But not that we can't overcome some of those initial predilections, as, most people, they don't like the taste of their first beer or something like that, right? But there is strong association, with alcohol use disorder and many others. So there's a strong family history component. So one of the things we're looking at doing, Dr. Tanveer Singh here is a child psychiatrist who has also trained in addiction medicine, and we're setting up a youth resiliency center to try to catch at-risk youth who have a history of parents with substance use disorder, perhaps some early use themselves, who have a history of trauma, who have mental illness. And I think that a lot of mental illness does impact, we know that a lot of mental illness impacts the reward circuitry adversely, depression, anxiety, others. So we're looking at providing some programming to help prevent the initiation of opioid use disorder in at-risk youth. And that'll be exciting to figure it out. Yeah. Yep.
Speaking of mental illness, I noted that you were talking about opioid receptors, and I know that there's some mental conditions out there where the receptors are affected, and I was thinking the proper psychiatric medication for mental illnesses reduce a population at risk for opioid abuse.
It's an interesting question, and so the systems are very complex. So it's more like our national air traffic control system than like I'm thinking about like how you how you drive into an airport and drop people off at a couple stations. So we tend to think about it being much more simplistically, like, like driving into an airport where you go into the parking lot, or, arrivals or departures, right? There's dopamine, serotonin, norepinephrine, right? But they're not, it's not as simple as that, because they're distributed and interconnect in complex ways, right? And so when someone has a mental illness, there may be a deficit of or an excess of a neurotransmitter, but then similar to what I was talking about when you're giving opioids, you're giving a replacement that's kind of going to the whole brain, right? So it could have unintended positive or negative consequences. Does that make sense to other levels? But what we do know is that treating mental illness really does help people with addiction. So treating both, and it's really important to treat co-occurring diagnoses. So it's not clear if it's because it's at the neurotransmitter level, or if it's really that your ability to cope, and manage the addiction and the withdrawal is going to be much, much better if you are physically healthy and mentally healthier, you know. So, yeah. I don't know if that makes sense, but.
Dr. McCullumsmith, thank you very, very much for all of your efforts here tonight and great information. We thank you very much. We thank those of you who are with us this evening, and we thank all of you who will be watching this live and online in the months ahead. Thank you so much for being with us.
Thanks. All right.